Great. Thank you everyone for joining us today for this webinar on finding the 1 in 3, how to identify, refer, and engage people with diabetes and pre-diabetes to the diabetes prevention program. As Sylvia mentioned, my name is Angela Forfia. I am the Senior Manager of Prevention at the Association of Diabetes Care and Education Specialists. I'm coming to you today live from Chicago, Illinois, and it's exciting to see so many people on this webinar, really from coast to coast, from the Bay Area to the Gulf Coast to the north, what we call the North Coast of Buffalo, New York, and the mountains of Denver and North Carolina and all of the places in between. So thank you so much for joining this webinar today. My role at ADCES is to provide trainings like this one and technical assistance and technology to advance diabetes prevention. And to make sure that quality diabetes prevention and quality diabetes care is available to everyone. So this webinar today, I hope, is just the start of a conversation between ADCES and the National Center for Farmworker Health and your organization on how we can support you to advance some of the things that we're going to be talking about in today's webinar. So at my very last slide, I'm going to be giving you my contact information. Please stay in touch. Please reach out. I would love to hear from you, and I would love to connect you with other resources that can support your work at your health center or your organization. So at the end of today's webinar, the start of our conversation together, you will be able to describe the National Diabetes Prevention Program, discuss opportunities to engage people with prediabetes in various community and clinical settings, explain how to identify individuals with prediabetes or at risk for type 2 diabetes in your electronic health record system, and then talk a little bit about how members of your team, your healthcare team, can refer people with prediabetes to lifestyle change programs. So I know that some of you on this call already know a lot about the National DPP. Some of you know a little bit or maybe a good amount about it. And for others, it's brand new information. And I know that you're probably at a variety of different places when it comes to thinking about this program. Maybe some of you had a pretty good program going and then COVID came along and you're trying to kind of get the ball rolling again. Or maybe you have a New Year's resolution to start a diabetes prevention program in your area, or to restart your program, or you need to, you're like, I've had this program going for a while, but I'm not getting enough people into my program. So wherever you are, some of the things that we're going to be talking about today, finding these individuals, finding this 1 in 3, are really going to help you, whether you're starting a new program, restarting your program, or trying to build a more successful and sustainable program over time. So we're going to start with the basics because this might be new information for some of you, but it's also going to be helpful in giving you talking points to talk to other people on your team about prediabetes and about the National Diabetes Prevention Program. So let's start with, what is prediabetes? Well, prediabetes is a serious condition where blood sugar levels are higher than normal. I always like to use the phrase when talking about prediabetes that it's a high risk state. This is serious to have prediabetes. Sometimes I think the word itself sort of, makes people think that it's like, oh, this is just kind of like a precondition and I really only have to worry when I have diabetes. But prediabetes itself puts you at a greater risk for developing type 2 diabetes, of course, but also for heart disease and stroke, even before a diagnosis of diabetes. So like diabetes, prediabetes is a very complex condition. There's a real interplay between our own genetic risk, if we have family members who have diabetes, our environment. So where are the environments where we work and play and live and worship? How are those environments affecting us? And, some of these things are really far outside our control of like what foods are accessible to us in our supermarkets. Are they really highly processed foods, or are they foods that like our great grandparents might have eaten, and our individual actions, our levels of like physical activity, how we're eating, if we have an active job, if we're doing a lot of like active moving around and, riding our bike and walking more than we're in our car. So there's lots of different risk factors that play into prediabetes. Our weight status, our age, as we get older, we have a greater risk for developing type 2 diabetes. Our family history, our parents, our grandparents, our brothers, our sisters, whether they have diabetes. Our race, ethnicity. So that's kind of like the big version of our family risk, is the risk that we might have from, being Scandinavian or being Chinese, or coming from, certain regions of our country of origin. Lack of physical activity, history of gestational diabetes. You can really think about pregnancy as kind of a risk test, sort of a stress test for your body. So if under that stress, you develop gestational diabetes, that puts you at greater risk for developing type 2 diabetes, and other conditions that are kind of related. So like polycystic ovary syndrome. So there's a really simple paper online risk screening that you can find at Do I Have Prediabetes? And we're going to kind of walk through that. But the only way to truly diagnose prediabetes is through a simple blood test, like an A1C or a fasting plasma glucose. So if you'd like access to some of these basics of prediabetes, you can find them on CDC's website. So there's a link right there. So now I want to talk a little bit about the kind of the overall prevalence of diabetes and prediabetes and the National Diabetes Prevention Program. So let's look at the really big picture. And as we look at the really big picture, you can also think about your own community, your own family, and kind of how these really big picture statistics kind of play out within your family, within your neighborhood, within your city, within your community, within your state, and especially within your health center. So kind of be thinking about the people that you're seeing within your health center. So looking at the US population overall, about 34.1 million adults, or about 13% of all adults have diabetes. About 1 in 5 don't know that they have diabetes. So these are individuals that are walking around in our community. If you stop them, you took a fasting plasma glucose or you took an A1C, they would have blood sugar that's in the diabetes range. So they have gone through prediabetes, they've developed diabetes, and they're unaware that they have this diagnosis. The percentage of adults with diabetes increases with age. So the older we get, the more at risk we are for developing type 2 diabetes. About a quarter of those over the age of 65 have diabetes. And diabetes is very serious. It's the 7th leading cause of death in the United States. And sometimes it's a contributing cause of death when, other factors are also involved. So prevalence of type 2 diabetes is highest among American Indians, people of Hispanic origin, and non-Hispanic African Americans. American Indians also had the highest prevalence of diagnosed diabetes for women at about 15%. Among those of Hispanic origin, those of Mexican origin had the highest prevalence, about 14.4%, but those of Cuban and Puerto Rican origin also have high prevalence. And education level is also a factor as well. So about 13% of adults with less than a high school education have diabetes versus 7.5% of those with more than a high school education. So again, it's kind of that complex interplay between our genetics, these social determinants of health, our environment, our education, kind of all coming together. When you look at prediabetes, this is where we have our 1 in 3. 88 million American adults have prediabetes. almost no one knows that they have prediabetes. About 8 in 10 individuals don't know that they have prediabetes. When you look at prediabetes, a higher percentage of men than women have prediabetes, like pretty significantly. That's why men, for us at ADCES, through our work, is one of the priority populations that we've identified. You know, they're at greatest risk of developing, of having prediabetes, of tipping into type 2 diabetes, but they're kind of underutilizing preventive care. Prevalence of prediabetes is pretty equally distributed across different education levels, racial and ethnic groups. So really what we're seeing is that individuals kind of tipping into type 2 diabetes unequally. So that's why doing prevention programs and kind of going upstream and working with populations that are more likely to develop type 2 diabetes is so important. Prevalence increases with age. So again, when we get to seniors, about 50% of seniors have prediabetes. But the good news about seniors is that almost a quarter of them know their status because they're more likely to be getting that regular health care. They're more aware that they have prediabetes, and so they can take action. So this slide has like a little picture. You know, 1 in 3 adults has prediabetes. It could be you, it could be your dog walker or your cat jogger. Maybe that's what my cats need. And this is part of an overall campaign that CDC is doing that's called Do I Have Prediabetes? And so we'll highlight some of those resources as we go through the webinar. And again, if you want to dive deep into these statistics, I put a link on this slide as well. So prediabetes is a big issue. It matters to ADCES. It matters to you here at this webinar. And the good news is that, you know, now that we're aware of this problem, there is a solution. There is an intervention that's very effective, that's proven to work to prevent or delay type 2 diabetes. And that program is called the National Diabetes Prevention Program. So we're going to travel back in time to the 1990s, you know, because every clinical intervention, you know, every vaccination, every new drug that's coming on the market has to start with a research study to see if it works. So the Diabetes Prevention Program study happened back in the 1990s, from 1996 to 1999. There were 27 different clinical centers across the country, and they enrolled more than 3,000 participants. I think they screened like almost 30,000 participants, identified these 3,000. 45% of those 3,000 were from these priority populations that we just talked about. So priority populations are these groups at high risk for developing type 2 diabetes. So they kind of over-enrolled individuals from these communities so that they could be sure that whatever intervention they were testing, it would work across the entire US population, which, you know, is kind of thinking ahead for the 1990s, because there's lots of clinical studies that happened back in the day where it was like, well, you know, we had a group of like white non-Hispanic men. And then it's like, I wonder if this works for women. I wonder if this works for like different ethnic groups. But they really started at the very beginning in having a very inclusive approach to this clinical study to see that it would work for all of us today who might be interested in preventing or delaying type 2 diabetes. So all participants had overweight or obesity, and all had what they called at the time impaired glucose tolerance. So we now call that prediabetes, but secret, you know, just between us, impaired glucose tolerance actually had a little bit bigger footprint than prediabetes. So they may have also included a few people in this study that had just been that we would today diagnose with type 2 diabetes. So it's a pretty like mixed group of people that were participating in this study. And they divided those folks into 3 different categories. So one category received a placebo with brief lifestyle counseling. So they went in, they got these prescriptions. The prescriptions had nothing in them. They didn't know that, and neither did their healthcare provider. And their healthcare provider also gave them some words of wisdom like, hey, you should get more physical activity and you should eat a healthy diet. The second group received intensive one-on-one lifestyle counseling. So they got to meet one-on-one with their healthcare provider, and the healthcare provider, didn't just say, hey, you should lose a little weight, you should get more physical activity, and you should eat a healthy diet. But they worked with them to accomplish those healthy eating goals, those physical activity goals, and those weight loss goals over an entire year. And then the third group, they also got a little bit of lifestyle counseling, but they mostly got the medication Metformin, which is an off-label use for treating prediabetes. It's sometimes used today, often used today for treating type 2 diabetes, but this is kind of like a experimental use of metformin for those with prediabetes. So they divided them up into these three groups, and they kind of saw what happened over these years of the study. And, as they got 4 years into the study, what they found out is that the individuals that were assigned to that intensive lifestyle change program reduced their risk of developing type 2 diabetes by 58%. And when they looked at the next most effective group, and those are the folks that received metformin, they found that that intensive lifestyle change was twice as effective as metformin for the general population. But it was even more effective for those over the age of 60. So the diabetes prevention program is one of those rare public health interventions that's the older you get, the better it works for you. So, it's not like too late for someone who's 60, who's been diagnosed with prediabetes, to really get a huge benefit from this program. They actually seniors kind of overperform in the diabetes prevention program. It really, really works for them. And because this all happened back in the 90s, we got to follow these folks over time. So, we were able to follow up in the early 2000s for our 10-year follow-up, and like maybe 2000, like 2010 for the 15-year follow-up. And what we saw is that even though people gained back some of the weight, and, they were no longer meeting with the doctor really intensively for an entire year, they still had reduced risk for developing type 2 diabetes. It's only when you get out to 15 years that these groups kind of converge a little bit. Metformin was effective with some of the participants of the original study. It was most effective with younger participants, women with a history of gestational diabetes, and those with the higher BMIs. So it's, again, these are not mutually exclusive. Someone can be taking metformin and also participate in a lifestyle change program. But these results were so astounding to the researchers that they actually ended the study early. It was supposed to be a 5-year study. So they ended it at year 4, and they rolled everyone into the intensive lifestyle change group because it was such a benefit for those participants. So that was a great study. Back in the 90s, the researchers were like, wow, this really worked. It worked for these 3,000 people. But we're going to have to roll it out for 88 million people today. And it's going to be really hard to do this intensive of a research study at scale for the entire population, a third of the population of US adults. So what they did from there is they tried to kind of translate that research into something that would work in our communities. It's one thing to do things in clinical research hospitals. It's another thing to do this in the real world. So the first thing they did is they took things out of the clinical research hospitals. I'm not sure if you've ever worked in a research hospital, but it's like, things are very expensive. It's hard to find rooms. It's like hard to, do kind of anything in a clinical research hospital. So they moved this program from the hospital out into community settings. So, they tried to do this program in YMCAs and senior centers and community-based health centers that were a lot closer to the people that needed to access these programs. And those were just as successful as these clinical research settings. Another thing, as you can imagine, that made this program super expensive is one-on-one interaction. So the healthcare providers were talking one-on-one with their participants. Well, I mean, you can think about this in your own center if, or you can think about this on today's webinar. If I had to repeat the same content to, all of the people that are on the webinar, it would really increase the cost, and the time that we all had to spend like on this webinar. So it's much easier and more sustainable to, instead of doing a one-on-one webinar, to do a 1-on-50 webinar or 1-on-100 webinar. And in this case, they didn't do that. They didn't move it to 100 people, but they did move it to 10 or 15 people. And that was just as successful as the one-on-one coaching, which was great. They also realized that you didn't necessarily need to have a doctor, a nurse, a pharmacist, a registered dietitian, a diabetes care and education specialist deliver this coaching. The community health workers, that paraprofessionals, that health ministry volunteers in churches could be trained as coaches, and they were just as successful as these clinical professionals. Later on, especially during COVID, we learned that the diabetes prevention program can be offered online or through distance learning. Again, that's a huge cost savings for this program. So when you start to put all these things together, it's like, oh, we don't have to do it one-on-one. We can do it in a group. We don't have to do it in the fancy hospital. We can do it within our own communities. We don't have to have an MD deliver this. We can have one of our community health worker paraprofessionals deliver this. And we can deliver this in multiple modalities. They saved a third of the cost of the original diabetes prevention program study. But they did keep some things the same. So they wanted to keep the same population because, I sometimes say, like, I'm here in Chicago and I could walk out on the streets of Chicago and, just find like the first 15 people I run into, and they would probably benefit from this program. It's like, hey, you're going to join a program where you get like a coach and you get to be you get to talk to somebody about how to increase your physical activity and how to look at the foods that you're eating and your eating patterns, and you get to manage stress. And they would be like, yeah, sounds good, sign me up. But I might not catch like 15 people that are likely to develop type 2 diabetes. So you want to identify like those 10 or 15 people that have the greatest risk of tipping into diabetes. And we do this by focusing on the risk scores of like how, do they have overweight or obesity? Do they have a family history of diabetes? How old are they? What's their level of physical activity? Do they have other conditions like high blood pressure? And by that risk screening, we know like, oh, we're finding a group that would be likely to develop type 2 diabetes in the future. You can also do that by looking at their past medical history. Did they have gestational diabetes when they were pregnant? Or doing a blood-based screening and seeing like, oh, you have a clinical diagnosis of prediabetes, so we know that you're more likely to develop type 2 diabetes. So you want to find that population that is a high-risk population. They also kept the duration. I am sure that it would be great if we could like, let's just do a long weekend and we'll figure all this out. But you really do need kind of a long time to, changing behaviors is not easy. So especially when you're talking about healthy eating and physical activity and stress and sleep and all of these different aspects of our lives. So it takes a long time to kind of complete this intervention and to make sure that these behaviors are going to stick over time. The dosage is also important. This is kind of like what I call the program intensity. So, the bigger dose of this program, the greater the chances people had of achieving success. So it starts with a dose of weekly sessions, so about 16 weeks of weekly sessions, and then it moves to a maintenance phase of bi-weekly or monthly sessions. So you want to make sure that people are getting a dose of about 24 hours over the year. And the outcomes are the same. So the program was still focused on weight loss of about 5% and physical activity of about 150 minutes every week. And with all of these things kind of working together, they found that this prevented type 2 diabetes for those who are at risk, or delayed the onset of type 2 diabetes. So let's take a look at what this looks like today. I have a little video, which hopefully you'll all be able to hear. So let me click play on this.
Imagine yourself 1 year from now. You've tackled your prediabetes. You're eating well, staying active, and reducing stress. You've even made new friends, all because you took charge of your health and lowered your risk for type 2 diabetes. It's possible when you join CDC's National Diabetes Prevention Program. Coaches help you with real-life solutions. This could be you. It can all start today. Find an online or in-person program. Visit cdc.gov/prevent-type-2.
All right. So that's kind of what the program looks like today. No referral. I do want to say this, that we're going to be talking now about identifying individuals with prediabetes, connecting them to the program. But I want to be clear at the very beginning of this discussion that no referral is needed. So anyone who qualifies, if you're sitting out there and you're like, maybe I qualify for one of these programs, you could, go to the CDC website, you could find one of these programs, you could walk right in the door. You do not need a referral from your primary care doctor to go to a national diabetes program in your area. Anyone who qualifies can also self-refer into a Medicare DPP. So even Medicare allows you to just take your Medicare card and walk right into a Medicare DPP program. You do not need a referral there. More and more states are starting to cover Medicaid DPP. So I saw somebody on a call from Illinois. So Illinois just started covering Medicaid DPP. And I don't know every state Medicaid DPP policy like the back of my hand, but based on what I do know, very few of them require referrals. So they're really kind of following along with what Medicare is saying. So some of you on this call, might be familiar with DSMES. So this is Diabetes Self-Management Education and Support. So you may have an accredited or recognized DSMT program where you're billing Medicare for these services, or maybe you're billing Medicaid for these services within your state. So when we talk about DSMES, we're talking about like, what are the 4 critical times for people to receive this education? We're going to look inside our EHR and find people that have been diagnosed with diabetes. Diabetes is usually pretty carefully watched in the clinical setting. And you're looking to, kind of get on the calendar for these primary providers that need to refer into DSMES. For prevention, we're going to have some slightly different strategies. We are going to be looking into the EHR, but we're going to be kind of an EHR detective and trying to find out what's in our EHR. We're going to be looking for opportunities to do convenience screenings, to do some of these paper screenings. And then we're also going to be looking at some of our other chronic disease self-management groups. So I'm going to put on my marketing hat for a second. And, if you've ever done marketing, this is kind of like the same process you go through for anything. Like maybe I'm, going to buy a new car, or I'm going to buy an advent calendar. I was Googling advent calendars the other day. So I know that advent calendars exist. I have some awareness. I know what advent is. So I'm interested in them. And then I'm like, okay, what advent calendars are available? There's some that have chocolate in them. There's some that have jam in them. There's some that, have little, figurines in them. Which of these do I want? And then I'm going to take action and I'm going to purchase one of these. So it's really the same thing when you're talking about health programming. And I really like this sort of these line of arrows around the bottom, where we know that 8 in 10 people are unaware. They do not know that they have prediabetes. If I did go out on the streets of Chicago and I was like, do you know what prediabetes is? I probably wouldn't even find people that knew what it was. And, if I just kept asking, maybe I asked 100 people, I'm only going to find maybe 20 of those 100 that are like, oh yeah, my doctor told me that I have prediabetes, that they have some awareness of that. So first you have to get them to an awareness of the problem. Like, oh, I have prediabetes and I know what this is and I know why it's important. I know what I need to do. So I'm like, oh, and I know that there's this thing called the diabetes prevention program I can sign up for. But the next thing is like, I might know about the diabetes prevention program, But do I know that this is available in my community? So is there a product that I can buy? So is there something somewhere I can sign up? And then when you're most aware, you can take that action and enroll in the program. So that's the process we're trying to take these folks through, from being problem aware to being solution aware. And, for DSMES, it's like, oh, I really want to talk to one of these diabetes care and education specialists. I want to connect with a diabetes self-management education and support services. For people with prediabetes, it's, oh, I want to find a lifestyle coach. I want to find a diabetes prevention program. I want to find one of these CDC-recognized lifestyle change programs. For DSMES, referrals are needed. So there's one extra step for DSMES where they, someone does have to go talk to their provider and say like, hey, would you write me a referral? For DPP, again, that's not needed. But people will talk to their providers anyway. They will go to their healthcare provider and say like, hey, I have prediabetes and I need support to prevent type 2 diabetes. And providers may be just as unaware of these programs as some people that I run into on the streets of my neighborhood. We like to think that our providers know everything, and they may have some awareness of the diabetes prevention program, but they may not know, like, where is it happening in my community? Can my patients afford it? Is it free? Is there a cost? I'm not going to refer somebody to something if it costs like $400 out of pocket. Does it work? Is it covered by insurance? So it's normal for providers also to have some questions. So you might be asking yourself, well, if individuals don't need a referral for a diabetes prevention program, even for the Medicare DPP, why does a recommendation, we sometimes call these recommendations, from providers matter? They can just go on their own. They don't need me. But healthcare providers, and again, you might be a healthcare provider yourself where you're like, oh, my voice really matters. Or you may be talking to the healthcare providers in your center and you can tell them how important their voice is, because they can increase awareness of prediabetes, increase awareness of these lifestyle change programs and their effectiveness. Let's be real, CDC is not buying like Super Bowl ads to tell people about the diabetes prevention program. So people are not, seeing this advertised to them all the time. They might see like a stray billboard, or maybe they see an online ad, but having the provider talk up these programs during an annual visit or during a wellness visit really matters. It also helps people with prediabetes kind of move from like, well, that kind of sounds good, but I don't know, my life's been really busy, like my job's been kind of stressful, I don't know if I want to do this, to taking action. So, just as with other things where providers can help people, make the decision to quit smoking or make the decision to, like have a certain screening or get vaccinated, providers can also help people kind of like weigh the costs and benefits of being a part of a diabetes prevention program. They're there to answer these questions. I'm here to answer questions that you might have about the DPP. But if someone out in the community is like, well, I have some quite like, what am I going to be doing? Am I going to have to share my feelings? Are we holding hands? Like, what's going on? They can ask their provider those questions. The provider can provide additional support and encouragement. And we know that when these healthcare providers recommend the diabetes prevention program, it increases the likelihood that people enroll, get engaged, and finish the program. We also know that sometimes people need additional support. The DPP is not going to do everything. If someone has clinical depression and they need the support for their mental health, that's going to help them in the DPP. So, the provider can still be there to support that. If they have sleep apnea, it's like, yes, some of the modest weight loss is going to help with that, but they may need some additional support for that as well. So the DPP is not like the be all end all of health. So we still need providers in the picture to support those things. Community referrals or recommendations also matter. So you might be one of these people. You might be like, I'm a faith leader, I'm a health ministry volunteer. Maybe you wear two hats. Like, I'm involved in my church, I'm also involved in my health center. I'm a community health worker, I'm a care navigator. So you can also do these recommendations to the diabetes prevention program. You too can increase awareness and answer questions and motivate participants and offer ongoing support and connect with healthcare. So you want to create both these clinical and community referral networks to ensure that people with diabetes are constantly finding your program and being connected with your program. So I'll take a brief pause because I was seeing a lot of chats pop up, but I was not having the chance to read them. So let me see if there's anything in the chat pane. And if you have any other questions, here's here's your chance to ask them as well. So 1 in 5 of the population don't know they have diabetes. That is correct. So it's about 20%, maybe like 21% of the population don't know that they have diabetes. And let me see if there's anything else. All right, well, if you have any other questions, here is the chat pane. So I will revisit the chat pane at the end of the webinar. So how do you find these 1 in 3? Well, the good news is that many of you are joining today from health centers, and health centers are fantastic places to identify people with prediabetes. You're engaged, you're effective with preventive care, with chronic care. You have great care teams that include community health workers, that include paraprofessionals, that include diabetes care and education specialists and other clinicians. You're accessible, you're affordable, you're engaged with your communities. You're located in a variety of areas. We saw all these areas, on the webinar today, from, urban neighborhoods to frontier communities to rural communities. And you're really trusted, and people rely on you for care for diabetes and for other chronic conditions. So just to, contrast your health center with some other places, faith communities, churches and temples and mosques, they're also really trusted places. They're also really accessible. They're also embedded in the community. They have a lot of time with community members. But I don't know about you, my church doesn't have an electronic health record system. They don't really know about any chronic conditions or health conditions that I may have. So they're very supportive of me, but they don't really have the whole picture of my health. They're kind of there for my spiritual health, but they may not have the complete picture. Hospitals are also great care providers. They're pretty trusted. If you're having an emergency, you will go to the emergency department. They're collecting health data. They see your electronic health record system. But people tend to go to those places for urgent care. So, you see a hospitalist. My mom often has this of like, I saw this really great hospitalist and I'd love to see him the rest of the time, but the hospitalist stays in the hospital. They are not seeing patients outside the hospital. So it's kind of that continuity of care is difficult when you're talking about a hospital. But when you're talking about your health center, and here's your little, medical home, you are trusted, accessible, you're embedded in the community, you have time with community members, and you do all of the same things that faith communities do, but you also do all of the same things that hospitals do. So you're really kind of like the sweet spot for doing diabetes prevention and diabetes care. So you probably don't have a ton of people running into your health center saying, I'm really worried I have prediabetes. But what you probably are seeing in your health center are all of these conditions that precede prediabetes or coexist with prediabetes. We call these comorbidities. So you may see individuals, and I 100% guarantee you're seeing individuals in your health center who have overweight and obesity and complications that are related to overweight and obesity. So sleep apnea, arthritis, lung function defects, reflux, gallbladder disease, mental health issues. Like these are all things that are kind of traveling in this cardiometabolic, constellation. You're seeing people that have high cholesterol, high blood pressure, heart disease, sleep disorders, gestational diabetes. So just, hopefully this is sounding familiar of like, yes, I can think of some patients right now that are coming into my health center with these conditions. So what we find is like, yeah, if I'm, again, doing my, walk around of my neighborhood, I might see 1 in 3 people with prediabetes, but people with prediabetes may be overrepresented within your health center. You're going to be seeing those folks that are coming in with these complications of overweight and obesity. You're going to be seeing folks that are coming in with related conditions. And you may even see people that are participating in other health center programs if they've been advised to make lifestyle changes. So I know a lot of the health centers in my community, they have walking programs, they have Zumba programs, they have community gardens. And those individuals with prediabetes may be overrepresented in those community-based programs as well. So one of the easiest ways to screen for prediabetes is this simple paper screening form. And I have it here in English and Spanish. You can find this on the websites below, and you can do the screening online, or you can just click and say like, I'd like to print this out and do it later. So you could print 50 copies of this. You could have this all over your health center. There's also a lot of like supportive like video information that goes with this. So we're going to see a video. The video is in Spanish. And I do not speak Spanish fluently, but even I understand the kind of like main points of this video. So I will kind of like talk you through them. But basically the video is going to talk through this prediabetes risk test. Age, gender, are you a man or a woman? If you're a woman, have you been diagnosed with gestational diabetes? Do you have a family member who's had diabetes? Have you been diagnosed with high blood pressure? Are you physically active, and what's your weight status? So we're going to look at this video together. I'll do a little simultaneous, not very good interpretation as we go through the video. There's English and Spanish versions of all of these materials online. All right.
Toma menos de un minuto saber si está usted en riesgo de padecer prediabetes. Puede averiguarlo aquí. Pero probablemente no lo hará, ¿verdad? Tiene usted la agenda llena, los hijos, el trabajo, su show favorito que ya regresa. Por eso, hagámoslo ahora. Si es hombre, levante un dedo.
So, are you a man or a woman?
Agregue 3
You're a man,
dedos
1
si
point,
tiene más
woman,
de 60
none.
años. Más de 50.
How old
2
are
dedos.
you?
Más
And
de
you give
40,
yourself a number of
un
fingers.
dedo. Si lo duda, no olvide
Are
que
you
está sentado
physically
en el
active?
sillón ahora mismo. Así que levante otro dedo si no hace usted ninguna actividad física. Agregue un dedo por sí y ninguno si es no.
Do you have family
Otro
members
por
with
sí
diabetes?
y ninguno
Do you have
si
high
es
blood
no.
pressure,
Elige la figura
hypertension?
que más se parezca a la suya. Agregue
And he's
la
got these
cantidad de
little
dedos que
images
aparecen
of
aquí y yo
overweight.
prometo no mirar. Si levantó 5 o más dedos, probablemente tiene usted prediabetes. Lamento ser tan directo con usted, pero solo me dio usted 1 minuto de su tiempo.
So this is a great example of a video that could be playing, that you could have embedded on your website, that could be playing in your waiting room, that could, you could push out it, like you could have it playing over and over infinitely at a health fair. So again, it's like the paper screenings are great. This is also sort of like, I will do these for like education of like, okay, everyone's going to walk out this room and they're going to know like how many fingers they raised. If it's more than 5, you are at risk for prediabetes. So these paper screenings can be a nice complement to that. And you can think about times to do them. There's great, like COVID has presented a very nice time to do a prediabetes screening because you have to wait 15, I had to wait 30 minutes because I have some allergies, wait 15 or 30 minutes after your vaccination. Any other preventive and chronic care programs, community programs, we're going to start to see some health fairs kicking off again. The heart of public health is health fairs. In your waiting room or other opportunities. So these paper screenings are very quick and easy to do, and you can make them a part of your existing sort of paperwork collection processes. So think about those times where you're like going through paperwork with patients and it's like, how can you integrate these paper screenings? Or like, I do these vaccinations and people are just sitting around looking at their phones afterwards. I'm going to have them do one of these prediabetes screenings. So if you're not doing blood-based screenings in your health center, you definitely should. There are some nice U.S. Preventive Services task force recommendations of, screening for obesity-related morbidity or mortality in adults. So, if hopefully you're checking height and weight, and so then you can calculate BMI, and you should be recommending intensive lifestyle change to those folks. And there's some new recommendations around prediabetes. These just came out in August, so it's like hot off the press. Asymptomatic adults who are between the ages of 35 and 70 who have overweight or obesity should be screened for prediabetes and diabetes. So, those folks should be receiving a fasting plasma glucose or A1C. So here's kind of a recommendation. All of this is on their website. You can sort of print this out for your clinical team members and say like, hey, we should really be screening, everyone who meets this criteria between the age of 35 and 70. So when can you do these blood-based screenings? Well, you can do them at annual visits as part of other preventive or chronic care programs. You can also do them in the community. I've done community-based blood-based screenings. The important thing there is you need to be navigating people back to care. You do not want to be screening them out in the community and being like, wow, you have an A1C of 12, good luck. You want to make sure that you're always able to kind of navigate them to care. These community screenings within your clinic, I always like the clinic-based health fairs because then you're right there within the clinical setting. Although blood-based screenings are a little more intensive than paper screenings, they can also be pretty easily integrated into the work of your clinic. So maybe you've been doing some of these and you're like, or you don't know, you're like, I'm gonna go back and check this out. The first place to look is in your EHR. So these are some of the diagnostic codes that you might see in your EHR. And these are specific. This excludes type 1 diabetes. It excludes type 2 diabetes. It excludes gestational diabetes. So these are the codes that, your clinical friends may have put into your electronic health record system that should kind of signal that that person, has prediabetes. So there is actually a prediabetes code, which is R73.03. But some of these other codes may have also been entered within your system. So let's say you go back, and we have some of our sites that do this. They go back and they're like, yeah, we found 5 people who have a diagnosis of prediabetes. It's like not even enough for my first group. So that's when you're going to have to be kind of an EHR detective. So the first thing that you have in your EHR is BMI. So that's where I would start, is I would find the people that have a BMI of greater than or equal to 25. And again, it's 23 for folks who are Asian American. So if you have Asian Americans in your EHR, you want to be looking at a lower BMI for their screening. You can also look at higher BMIs within that group. So it's like, if you're looking for like a high risk group, you might be like, oh, I'm gonna cut it off at like 27. I'm gonna look for people with a BMI of like 27 or BMI of 30, because then I really know that I'm going to be identifying a higher risk group. You can also look for other diagnosis codes that indicate progression of prediabetes. So if you have someone who has a BMI of 25, they're metabolically healthy, they have a low blood pressure, low cholesterol, it's like that might be not the best candidate for your group. But if you have someone who has a BMI of 30, they're on a couple, 2-3 medications for high cholesterol, for hypertension, for some other, for reflux, that's someone who might be kind of a good candidate because they're already experiencing some of the health impacts of prediabetes. You can also use your patient portal or reminder system to encourage screening. So you could encourage people to do that, like quick and easy screening through your patient portal. If you look in your database and you're like, I got 5 people with prediabetes, that might be a sort of indicator to you that you want to increase your screening rates. So the American Medical Association, I can't do, I'm going to promote their materials because they have some great materials on their website to really take your center through the process of like, what do I need to put into place to make sure that everyone who's coming into my center who, is 35 to 70 who has overweight or obesity, whether that's 25 for the general population or 23 for Asian Americans, they're getting screened. So I can start to, I don't just have 5 people in my system that have prediabetes. I'm starting to have a more accurate representation of the people who have prediabetes so that I can actually recruit them for my diabetes prevention program. So they have a lot of great resources on their website. I just pulled a couple of them here. The other place that I would look within your, again, you're a detective, so you're trying to find this 1 in 3, is look in your other chronic care management programs. So if your center is already doing chronic care management and you have folks, these are folks that, have, another chronic, 1 or more than, I think it has to be 2 chronic conditions. So, you have people that are like, they got arthritis and AFib, they have cardiovascular disease, COPD, they have depression, hypertension. All of these are kind of traveling along with prediabetes. So, look within your chronic care management folks who are already participating in this program, because they are very likely to be at risk for developing type 2 diabetes. There are lots of things that you have going on in your center. I have like this little one random animated slide. So, you might have that summer gardening program that my local FQHC has. Maybe you have fitness classes. Maybe you have a walking program. Maybe you have men's or women's health programming. Maybe you have drop-in support groups. Maybe you have that chronic disease self-management. So it is always easier to tip somebody into a 12-month intensive program if they're already doing something. If they are doing nothing and they're not involved in anything at your health center, it's very hard to take them on this heroic journey from like a 45-minute lunch and learn into an intensive 12-month program. It's much easier to tip somebody into this that are already doing some of the programs at your health center. And the good news about this too is that you get to have support for them after you end your program. So after your 12 months is over, it's like, great, well, keep doing that fitness class. Or why don't you sign up for our summer gardening program? So it's both an on-ramp and kind of an off-ramp to your intensive program. So there's loads of great resources out there for you. You absolutely do not need to reinvent the wheel on any of this. There's lots and lots of support that's available. Here's some links on this page. And again, stay in touch with me. And if you are joining us today on the recording, and you're like, listen to this recording. Thank you for listening to this recording. You can send me an email, you can give me a call, and then we can talk live one-on-one about anything. If you've joined us live today, stay tuned, and we're going to do some live questions and answers in just a few minutes. So regardless of how you joined us, thank you so much for listening, and I look forward to talking to you soon.